Hi, my name is Beckim Torres, a student of the Qualitest Medical Laboratory and Ali Health Training, and this presentation is based on phlebotomy to be presented to lecturer Yvette Orvin. Phlebotomy is the act of removing blood from the body by puncturing a vein or capillary with the use of a needle or lancet for diagnosis and monitoring of treatment, transfusion, and therapeutic purposes. Function of phlebotomy: trained to collect blood samples for lab analysis to help in the diagnosis and care of patients. Purpose of phlebotomy: prepare patient for collection procedure for laboratory samples. Collect routine skin punctured and venous specimen for testing as required. Promote good relationship with patient and hospital personnel. Maintain safe working conditions. Performing quality control checks while carrying out duties. Equipment and supply used by phlebotomists: blood drawing station, phlebotomy chair, glove and glove liners, disinfectant and hand sanitizers, gauze pads and cotton balls, needles and sharp disposable container, bandage, pen and watch, and antiseptics. The H-shaped venous distribution pattern is displayed by approximately 7% of the population and includes the median cubital vein, cephalic vein, and basilic vein. Median cubital vein, located near the center of the antecubital area, it is the preferred vein for venipuncture in the H-shaped pattern. It is typically large, closer to the surface, better anchored, and more stationary than the others, making it the easiest and least painful to puncture and the least likely to bruise. The vein that form the M-shaped venous distribution pattern includes the cephalic vein, median cephalic vein, median basilar vein, and basilar vein. This vein most commonly used for venipuncture in this distribution pattern as described as follows. Median vein, also called the intermediate antecubital vein, the first choice for venipuncture in the M-shaped pattern because it is well anchored, tends to be less painful to puncture, and is not as close to the major nerves or arteries as the other, making it generally the safest one to use. Phlebotomy needles are sterile, disposable, and designed for a single use only. They include multi-sample needles, hypodermic needles, and wing infusion, well known as butterfly needles used with both the evacuated tube system and the syringe system. Multi-sample needles are commonly enclosed in steel twisted off shield or cover. Hypodermic needles and butterfly needles are typically sealed in sealed pull-apart packages. Parts of the evacuated tube systems consist of needle, safety shield, holder, evacuated tube. Parts of the syringe system consist of the shaft, barrel, and plunger. Common stopper color additives and department: light blue, sodium citrates, coagulation; red, non-additive, chemistry, blood bank, serology, immunology; red, clot activator, chemistry; red, light gray, non-additive, non-discard, tube only; clear, red, black, Tigger, clot activator and gel separator, chemistry; gold, red, gold; green, gray, light green, lithium, heparin and gel separator, chemistry; green, lithium heparin, sodium heparin, ammonium heparin, chemistry; lavender, purple, EDTA, hematology; royal blue, non-additive, chemistry; tan, EDTA. Order of draw, stopper colors, and rationale for collection order. Blood culture, sterile collection, yellow SPS, sterile medium bottles, medium chance of microbial contamination. Coagulation tubes, light blue. The first additive tube in the order because all other additive tubes affects coagulation tests. Glass non-additive tube, red. Prevent contamination by additives in other tubes. Plastic clot activator tube, red. Fill after coagulation test because silica particles activate clotting and affects coagulation test. Carrying over of silica into subsequent tubes can be overburdened by anticoagulant in them. Sodium separated tubes, STS tubes. Red and gray rubber, gold plastics. Plasma separated tubes, PSTS heparin tubes, green and gray rub or light green, plastic green. Heparin affects coagulation tests and interferes in collection serum specimen. It causes the least interference in tests other than coagulation tests. EDTA tubes, plasma preparation tubes, PTTS, lavender pink or purple pearl top, responsible for more carrying over problem than any other additive, elevates Na and K level, chelates and decreases calcium and iron level, elevates PT and PTT results. Oxalated fluoride tube, gray, sodium fluoride and potassium oxalate affect sodium and potassium level respectively. Fill after hematology tube because oxalate damages cell membranes and causes abnormal RBC, morphology, oxalate interference in enzyme reactions. Components of phlebotomy tray are syringe, multi-sample blood collection needles, tourniquet, safety trainer device, blood culture bottle, microcontainer tube, BD Eclipse, Portex Needle Pro, microchromatic tubes. Routine ETS venipuncture. Review and accession test requests. Approach, identify, and prepare patient. Verify diet restriction and latex sensitivity. Sanitize hands. Position patient, apply tourniquet, and ask patient to make a fist. Select vein, release tourniquet, ask patient to open fist. Clean and air dry site. Prepare equipment and put on gloves. Reapply tourniquet, uncap and inspect needles. Ask patient to remake a fist, anchor vein, and insert needles. Establish blood flow, release tourniquet, ask patient to open fist. Fill, remove, and mix tube in order of draw. Place gauze, remove needle, activate safety features, and apply pressure. Discard collection unit. Label tubes. Observe special handling instruction. Check patient's arm and apply bandage. Dispose of used and contaminated material. Thank patient, remove gloves and sanitize hands. Transport specimen to the lab. Venipuncture of a hand vein using a butterfly and ETS holder. Sample as routine ETS venipuncture. Position hand, apply tourniquet, ask patient to close the hand. Select vein, release tourniquet, ask patient to relax hand. Clean and air dry site. Prepare equipment and put on gloves. Reapply tourniquet, uncap and inspect needle. Anchor vein and insert needle. Establish blood flow and release tourniquet. Fill, remove and mix tube in order of draw. Place gauze, remove needle, activate safety device, and apply pressure. Discard collective unit. Needle and syringe venipuncture. Same as routine ETS venipuncture. Prepare equipment and put on gloves. Reapply tourniquet, uncap and inspect needles. Ask patient to make a fist, anchor vein, and insert needle. Establish blood flow, release tourniquet, ask patient to open fist. Fill syringe. Place gauze, withdraw needle, active safety device, apply pressure. Discard needle, fill tube, discard syringe, and transfer device. Pediatric venipuncture. Collecting blood by venipuncture from infant and children may be necessary for tests that require large amount of blood, example, cross-matching and blood culture, and tests that cannot normally be performed by skin puncture, example, ammonia level, and most coagulation studies. Venipuncture in children under the age of 2 should not be limited to superficial vein and not deep, hard to find vein. Normally, the most accessible vein of infant and toddlers are of the vein of the antecubital fossa and forearm. Other potential venipuncture sites include the medial wrist, the dorsum, the foot, the scapula, and the middle ankle. Venipuncture of these sites, however, requires special training and the permission of the patient's physician. Capillary puncture. Review and accession test requests. Approach, identify and prepare patient. Verify diet restriction and latex sensitivity. Sanitize hands and put on gloves. Position patient. Select the puncture incision site. Finger stick procedure. Sanitize hand and put on gloves. Position the patient. Select the puncture incision site. Warm the site if possible. Clean and air dry the site. Prepare the equipment. Puncture the site and discard the lancet incision device. Wipe away the first blood drop. Fill and mix the tube containers in order of draw. Place gas and apply pressure. Label the specimen and observe special handling instruction. Check the site and apply bandage. Dispose of used and contaminated materials. Thank patient. Remove gloves and sanitize hands. Transport specimen to the lab. Heel stick procedure. Sanitize hands and put on gloves. Position the patient. Select the puncture incision site. Warm the site if applicable. Clean and air dry the site. Prepare the equipment. Puncture the site and discard the lancet incision device. Wipe away the first drop of blood. Fill and mix tube containers in order of draw. Place gauze and apply pressure. Label the specimen and observe special handling instruction. Check the site. Dispose of used and contaminated material. Thank parents or guardian. Remove gloves and sanitize hands. Transport specimen to the lab. Possible problem site. Certain areas are to be avoided when choosing a site. Extensive scars from burns and surgery. It is difficult to puncture the site tissue and obtain a specimen. Patient's complications and condition. Allergies to equipment and supplies. Adhesive allergies, antiseptic allergies, latex allergies, excessive bleeding. Step to follow if a patient starts to faint during venipuncture. Release the tourniquet and remove and discard the needle as quickly as possible. Apply pressure to the site while having the patient lower the head and breathe slowly. Talk to the patient. Physically support the patient. Ask permission to explain what you are doing if it is necessary to loosen a tight collar or tie. Apply cold compress or wet washcloth to the forehead and back of the neck. Have someone stay with the patient until recovery is complete. Call first aid personnel if the patient does not respond. Document the incident according to facility protocols.